Good afternoon. It is a huge honor and a privilege for me to be presenting today the Feliciano Rosicki Historical Lecture. I think, as many of you know, Southeastern Surgical Congress has a huge place in my heart. I became a faculty member in 2004. I presented my first paper here, I believe, in 2003. Actually, it was February 2004, and I don't think I've missed a meeting since. It's probably my favorite organization. And one of the things that makes this organization so special, which I think you hear time and again, is the relationships you have the opportunity to develop. So two of the people who I have met through this organization who have been the hugest mentors to me in the organization are named, have made this lecture a reality. So Dr. Rosicki and Dr. Feliciano, I hope I do you proud, and I'm really honored to present in your name. Surgical history is a little bit difficult for me. I'm good at a lot of things, but I'm actually really bad at history. I'm going to be perfectly honest. So when I found out I had the opportunity to give this talk, I thought, oh my goodness, what am I going to talk about? My husband and my son are both huge history buffs. And when I told them I was giving a history talk, they said, Mom, you're really well schooled, but you're not well educated in history, so this is going to be very interesting. So I decided, well, I'm going to have to find a topic that is engaging to me, that I'm interested in, and that I can actually do this history thing well. I started to look at thinking maybe I can talk about quality or patient safety or surgical infection. And as I was starting to do a little bit of my research, I found lots of interesting vignettes about surgical attire. So with that as the background, what I chose to talk about today is the history of surgical attire. There's actually a love story within the history of surgical attire, thus my name, The Glove Made for Love. And again, this is a really interesting history, both of quality, of surgeon resistance to change, and I think of patient outcomes in the end. I did want to give an acknowledgement to Dr. Don Nakayama, who shared he wrote an excellent paper in the American Surgeon in 2018 that I found when I was doing my research, and it was about asepsis and antiseptic techniques. And I reached out to him to get a copy of his manuscript, and he also shared quite a few pictures with me, so thank you very much as well. So when one thinks of a surgeon today, I think we all have our idea of what a surgeon in the operating room is going to look like. They're going to be probably wearing scrubs. They'll probably be either blue or green scrubs. Likely they'll have a gown on. They'll have a hat on. We'll talk about hats a little bit later. They'll have a mask on, and they'll have gloves on. But this really has only been in evolution for about the last 100 years. Prior to the 19th century, surgery was really performed in street clothes, where the surgeon would come in, they would roll up their sleeves, and they would operate. In the mid-19th century, it became common for surgeons to operate in what's called a black frock coat, which was a bloody and pus-stained coat that was handed down from surgeon to surgeon as a badge of honor. Common 19th century attire is well described by Lord Moynihan of Leeds in this slide, where he says, "The surgeon arrived and threw off his jacket to avoid getting pus or blood on it. He rolled up his shirt sleeves and in the corridor to the operating room took an ancient frock from the cupboard. It bore signs of a checkered past and was utterly stiff with blood. One of these coats was worn with special pride, indeed joy, as it had belonged to a retired member of the staff." Much of what we know about the history of surgical attire actually comes from the review of photographs. And it's really interesting looking back at some of these photographs. So this was a very well done paper in 2016 published in Anesthesiology that looked at surgical attire and looked historically at surgical attire. So what you see here on these slides, this is the year something was introduced, and this was when about 50% of people in photographs were found to be wearing it, and then at the end of the arrow is 90%. So what you can see in this slide is that we started with wearing gowns, then caps, then gloves, and then masks. So caps weren't worn by 50% of people until approximately 1904, gloves in 1911, and masks in 1919. What's also very interesting, and remember this was published in an anesthesiology journal, when they looked at anesthesiologists versus surgeons, they lagged behind by anywhere from 10 to 20 years in adopting each of these things. So what we're going to do over the next 30 minutes is look at some of the history of surgery and how we started where we were and how we got to where we are now. As many of you know, surgical mortality in the early and mid-19th century was greater than 50%, with hospitals being referred to as houses of death. It was noted in the mid-19th century that mortality at childbirth was markedly higher when the delivery was done by medical students as compared to people delivering at home or being delivered by midwives. The cause of death was childbed fever, also known as puerperal fever. This disease progressed rapidly within the first 24 hours after childbirth, with patients experiencing high fevers, severe abdominal pain, and abscesses, followed by death. In 1843, Dr. Oliver Wendell Holmes presented a paper in Boston at the Boston Society for Medical Improvement, where he suggested that childbed fever could be transmitted from one person to the other. He argued that at the time very controversial view that perhaps the doctors were actually spreading this disease from one patient to the next. This view, as you can imagine, was quickly attacked by all the leading obstetricians who thought that he was being completely crazy and this couldn't possibly be the case. Several years later in Europe, Dr. Ignaz Semmelweis made similar observations. He worked in Vienna, and what he observed was, again, that medical students had a much higher rate of mortality with their patients than the midwives. The only difference he could find in the care given to those patients was that the medical students were starting their morning performing autopsies on the patients who had died the day before of childbed fever. From there, they would come over and deliver, and their mortality was significantly higher. So he proposed that there was a quote-unquote morbid poison that these medical students were actually bringing from those dissected corpses into the laboring patients. He therefore required that those attending autopsies in the morning wash their hands with a lime chloride solution, and he immediately noticed a decrease in maternal mortality. Similar to Dr. Oliver Wendell Holmes, he encountered significant resistance from physicians who strongly believed at the time that it was actually bad airs or a balance of humors that was off within patients that was causing them to die. Sadly, he made his discoveries at a time when medicine was really not interested or willing to listen to what he had to say. He became increasingly erratic, and by 1850 had actually lost his appointment at the Vienna hospital. He did go on to publish his theories on childbed fever in 1861, and there was significant vitriol directed at him for his findings. He became more and more erratic, was actually committed to an insane asylum, and died at the age of 47 in 1865. Of course, as we know now, the cause of childbed fever was group B streptococcus, whoa, how did I do that? Sorry. Depicted here. And the theory of hand washing actually worked very, very well. Perhaps we can all honor Dr. Semmelweis by merely washing our hands. Dr. Holmes and Dr. Semmelweis introduced the concept of asepsis at a time before it was accepted. Asepsis is the avoidance of bacterial contamination in the operating rooms. It wasn't, however, until later in the 19th century that the surgical world would become aware of the concept of antisepsis with the work of Dr. Joseph Lister and Dr. Robert Koch. Dr. Louis Pasteur published in 1858, he did work on airborne microorganisms and noticed that this could ferment wine as well as spoil milk. So Dr. Lister wondered if that same process could be occurring in his surgical wounds that were exposed to air. He then collaborated with a chemist, Dr. Richard Anderson, who was working to neutralize the smell of diverted sewage by using a carbolic acid solution. Dr. Lister realized that his surgical wounds had this similar smell to this sewage, and perhaps if the carbolic acid would work on sewage, it would also work on our wounds. He made a connection, and he decided to try this carbolic acid as treatment. In 1867, Dr. Lister published a series of 11 patients, 9 of whom had had a good outcome after using carbolic acid to treat open fractures. He was convinced that the microbes that were responsible for surgical infection were coming from the air, and he experienced with a different variety of ways to actually treat the wounds with this carbolic acid solution. In 1871, he introduced a spray of carbolic acid, and this became known with the eponym of Listerism. Pictured in this slide here are some of the components that some of you may know are Listerism. So you can see there's the spray there containing the carbolic acid. There are towels draped over the patient that have been dripped in carbolic acid. and the instruments are all sitting in this little vat here of carbolic acid. Interestingly, the theories of Lister were also extraordinarily controversial at the time, and many of the most famous surgeons that we know now had strong pro and con views of his work. Some famous pro-Listerian surgeons include Dr. Billroth of Vienna and Dr. Halsted of Johns Hopkins Hospital. The most famous anti-Listerian surgeon was Dr. Tate of London, and Dr. Tate contended that he had done hundreds of abdominal operations without having major problems, and that he thought these ideas were crazy. He also was really the first surgeon that I could find historically to say, show me the data, I want to see more results. The major source, I believe, of the conflict over antisepsis at the time was the underlying lack of clarity of the relationship of bacteria to infection. Even the most staunchly pro-Listerian surgeons, such as Dr. Billroth, were really uncertain as to whether the bacteria were the cause or the result of the infection. Interestingly, Dr. Lister felt that because he used this carbolic acid, he could relax some other practices. So he was known to have twice the amount of patients as anybody else on the surgical wards, and often would put 2 children to recover on the same stretcher. In regards to surgical attire, notably, Dr. Lister continued to operate in his black frock coat all the way until his death in 1893. In 1876, Dr. Robert Koch was the first scientist to link a germ to a specific disease when he discovered that Bacillus anthracis caused anthrax. He later won a Nobel Prize for his work on tuberculosis, where he detected bacilli in the sputum and concluded that the sputum was actually the primary source of transmitted disease. In 1878, he did experiments where he could actually link bacteria to wound infection by injecting mice and rabbits with various bacteria and demonstrating that this would develop wound infections. His work was really critical in developing the relationship of bacteria to infection, and this really led to the development of aseptic techniques based on the avoidance of the introduction of bacteria rather than treating the bacteria that was already there, such as antisepsis. By the 1880s, the work of these famous surgeons had led to a ripe stage for the development and changes in surgical attire. So in the late 1800s, surgeons actually started to cover their clothing, usually with a white unsterilized towel. Really, the surgeons were doing this more for their own protection than for anything else. In 1885, Lucy Osborne, who is the lady superintendent of the Sydney Hospital, wrote to her mentor, Florence Nightingale, "The doctor and all of his assistants take off their coats and have tied round them garments of white mackintosh, which cover them from chin to toe, a kind of white cotton surplice with loose sleeves coming to the elbow. This latter is changed after every case." So you can see here, however, while the surgeons are covered in white and no longer wearing their black frock coat, except for Dr. Lister, you still see the nurse is here in her black gown. No one's wearing gloves, no one has a mask on, and all of the people watching the surgery have just walked in their regular street clothes. In reviewing the photographic history, as well as the medical history, the last 20 years of the 19th century are the significant time of change from the traditional frock coats to the newer white clothing, gowns, sterilizers, and aseptic techniques. The first known use of a surgical gown was the German surgeon Dr. Gustav Neuber in 1883. He used mercuric chloride to sterilize his gown and wore this. And what's very interesting about this, however, is that the one that is credited with gowns is Dr. Ernst von Bergmann. If you look at Ernst von Bergmann, even he will give Dr. Neuber credit, but in all of the surgical history you find, they talk about Dr. Bergmann. Dr. Bergmann certainly is credited with describing steam asepsis, both for the gown as well as instruments. And this painting of Dr. Bergmann in Berlin represents that time, I think, very well, with some of the aseptic techniques of the time. Again, you'll see the steaming of the instruments, as well as all of the surgeons in their white gowns. Again, you'll note here that no one's wearing gloves, no masks, no caps. So by the mid-1890s, aseptic and antiseptic techniques were really fairly well accepted. Dr. William Halsted was a staunch Listerian and believed in sterilization of his instruments as well as stringent hand washing. Miss Carolyn Hampton was the chief nurse of the operating room under Dr. Halsted at Johns Hopkins Hospital. Miss Hampton was the niece of Confederate General Wade Hampton III, who was the governor of South Carolina as well as a U.S. senator. Both of Miss Hampton's parents had died in 1862, and she was raised in a small house behind Millwood, which was the plantation owned by General Hampton that had been burned to the ground by Sherman's troops in 1865. She rebelled against her upbringing and in 1888 moved to New York to go to nursing school and graduated. She then joined the operating room staff at Johns Hopkins Hospital, and a very famous quote was stated by Dr. Halsted after Miss Hampton had developed a severe dermatitis to the scrub that he required her to use for her hands. In the winter of 1889 and 1890, I cannot recall the month, the nurse in charge of my operating room complained that the solutions of mercuric chloride produced a dermatitis of her arms and hands. As she was an unusually efficient woman, I gave the matter my consideration, and one day in New York requested the Goodyear Rubber Company to make as an experiment 2 pairs of thin rubber gloves with gauntlets. On trial, these proved to be so satisfactory that additional gloves were ordered. He then goes on to say, in the autumn, on my return to town, an assistant who passed the instruments and threaded the needles also was provided rubber gloves to wear at operations. At first, the operator only wore them when exploratory incisions into joints were made. After a time, the assistants became so accustomed to working in gloves that they also wore them as operators and would remark that they seemed to be less expert with the bare hands than with the gloved hands. So this quote is famous for 2 reasons. Number one, it's credited with describing really the reason that Dr. Halsted had them make the first pair of rubber gloves. But it's also a representation in the medical literature of a love affair that bloomed between Miss Hampton and Dr. William Halsted. In the June of 1890, they were married. They honeymooned down at the Hampton Hunting Lodge in Cashiers, North Carolina. They liked the area so much that they actually purchased 400 acres and named the area High Hampton. Miss Halsted would usually live at the High Hampton from May until November, and Dr. William Halsted would come down from June until October. It's rumored that he really disliked the hot air in Baltimore in the summertime. The two are described in the literature as opposite in every way, particularly in the way they dressed and in the way they act. But they had a remarkable love affair with each other, and they were happily married for 32 years until their death in 1922. So this is a picture of one of the original gloves made by the Goodyear Company. And while Dr. Halsted is popularized with crediting the, while he's credited for popularizing the use of rubber gloves, it's actually unknown who the first surgeon to wear gloves was. In 1878, there was a gynecologist, Dr. Galliard Thomas, in New York City, who did allow some members of his operating team to wear gloves in response to their difficulty with the scrub. Interestingly, even though Dr. Halsted was a strict Listerian and very much believed in cleanliness and antiseptic techniques, he himself did not start to wear gloves. The glove, they felt, was really introduced more to combat dermatitis, and really they didn't think it had anything to do with surgical infection. His protege, Dr. Joseph Bloodgood, was actually the first of the surgeons that operated with him to really popularize the use of gloves, and he started this in 1896, so 7 years after the glove had been introduced for Miss Hampton. In 1899, he published a report of 450 hernia operations done while wearing gloves, with an almost 100% drop in the infection rate attributed to gloves. It's unclear in reviewing the history why there was such reluctance by surgeons to wear gloves. Although some of them did talk about concern with the loss of tactile sensation and overall resistance to change by the surgeons. There was also some consternation about, did we really need to have gloves, or could we just wash our hands well? As well as there was difficulty with the materials in terms of how to sterilize the materials. Dr. Halstead was noted to wonder in retrospect why he was, and I quote, blind as to not have perceived the necessity for wearing them invariably at the operating table. So he is one of the famous surgeons in retrospect to admit that he was wrong. The mask was not nearly as controversial as gloves, although it was the last of the surgical garb to truly be accepted by surgeons. Dr. Johann Michelitz is credited with introduction of the mask around the turn of the 20th century. He justified the need to wear a mask based on the work of Dr. Karl Fluge, who had demonstrated bacteria in droplets from the nose and the mouth. The Spanish flu epidemic, which killed 50 million people from 1918 to 1920, resulted in the use of cotton masks to cover faces. It is also recognized in reviewing photographic evidence, as well as surgical history, that it wasn't until World War I that surgeons in the operating room were routinely wearing masks. Surgical scrubs were first introduced by Dr. Robert Hunter back in 1894, when he postulated that, and I quote, "It is safer and better that all should put on a complete change of costume rather than simply don a sterilized coat and a pair of trousers over ordinary clothing." So what you can see in the pictures here, this first picture was in the early 1900s. Again, you see many of these white gowns. Most of the surgeons are wearing caps. You'll note that one or two of them are wearing a mask, but it's certainly not universal. And I couldn't tell, but very few seem to be wearing gloves. In the upper right corner, this is a picture from the 1950s. So here you see everyone has a mask, everyone has a cap, everyone has gloves, and they're wearing the white surgical scrubs. What happened was evolution in lighting in the operating rooms made it so the white scrubs were actually making it really difficult to see. And that is how we evolved from the white scrubs of the 50s to the current greens and blues that are commonly seen today. This controversy still exists about surgical attire even today. This is covered both in the lay press as well as in the surgical literature. The Association of Perioperative Nurses, or AORN, in 2014 published guidelines for personnel entering the operating room and stated that they should cover the head, hair, ears, and facial hair. They based these recommendations on the concern that the hair and skin could harbor bacteria and may increase infection risk by dispersing this into the operating room air. At the time, several major hospitals were cited for surgeons having either hair or their ears exposed. As you can see on the right, the Brigham and Women's Hospital in Boston was one of those hospitals cited. And this is the front page of the Boston Globe, stating no more surgical caps for surgeons. It goes on to be a multiple-page article about the controversy. As many of you recall, there was tremendous uproar as this was covered, particularly among surgeons and particularly in response to the skull cap. The American College of Surgeons responded by stating that the skull cap was symbolic of the surgical profession. Dr. David Hoyt, the executive director, wrote a response stating that the American College of Surgeons guidelines, which we put out in 2016 as a response, were based on professionalism, common sense, decorum, and available evidence. The American College of Surgeons guidelines stated that we should be able to wear whatever cap we wanted if there was limited hair or at the back of the neck or sideburns exposed. What was fascinating about this debate, which raged on, was the lack of actual evidence that the AORN guidelines were based on. The AORN did have a rebuttal to the American College of Surgeons, and they stated that we should base guidelines on evidence and not symbolism. So, as surgeons are often prone to do, a decision was made to study this. And in 2017, Dr. Merkel led a study to investigate airborne contamination with different types of surgical caps. He studied hats, which is best. The bouffant cap on the left that covers everything, including the ears, the cloth scrub cap on the right, or the disposable skull cap in the middle. What he didn't study, and perhaps he should have considered, was whether no cap at all would be warranted, but that's not a part of the study. Interestingly, this study concluded that the disposable bouffant cap actually had greater permeability, penetration, and greater microbial shed when compared to the disposable or the cloth skull cap. In light of this study, as well as the ongoing controversy, a task force was convened in 2018 with all of the players involved. This task force had representation from the AORN, the American College of Surgeons, the American Society of Anesthesiologists, the Association for Professionals in Infection Control and Epidemiology, the Association of Surgical Technologists, and the Joint Commission. The guidelines were actually open for public comment, which closed yesterday and are expected to be published in April of 2019. But the preliminary results that they found were, number one, that there was no evidence that covering the ears made any difference. That, number two, these guidelines should be collaborative with all of the players at the table when making them. And that, number three, there was no scientific evidence that supported different types of hair coverings and infection rates. I think the history of surgical attire is really a fascinating look at quality and patient outcomes, and a really fascinating look at, well, at surgeons' resistance to change. And hopefully in the future we may be less resistant to change. It really is remarkable when you look back and you think to yourself, how could they pick up a black frock coat that maybe Dr. Britt's going to hand me down a black frock coat and I'm going to wear it in his honor, but that just to us seems unfathomable. The dichotomy is still seen even today, though, when we're still arguing about caps in the operating room and which one is better. I think that in the next 100 years, we're going to see really significant changes in quality measures and outcomes research, and this may impact how the surgeon looks in the future. We don't know what a surgeon's going to look like 100 years from now. It's possible that a surgeon's going to look like this robot here, and that would certainly change the attire for surgeons. I can tell you the surgical attire is already changing and continues to change in hospitals each and every day. So perhaps the future of surgical attire, the long white coats are going to be officially replaced by the black fleece jacket as seen in many hospitals in 2019. Again, thank you for the opportunity to present this surgical history lecture in my mentor's name, and I would be happy to take any questions.